Well, hello, everyone. I'm Maria Theodoulou. I am a breast medical oncologist up in the Capital District and Hudson, New York, with New York Oncology Hematology. I'm really excited tonight because we have a great panel now that we're resuming our survivorship program. It was a huge success last year. And thank you, Stacey, for supporting us last year, and to all the other donors that supported us. But more importantly, thank you for supporting us this year and being there as an advocate for all patients. Stacey, say hello. And
hello.
I'm actually going to introduce Stacey first, and then we're going to go around for the audience that's watching us. And I hope you all find this interesting, because this whole topic was born of a conversation I had with one of the physicians on this panel, Dr. Joan Kent, and we're going to get to her. But first, I want to introduce Stacey. She's the beautiful woman in the red, and I can't describe a more involved, more on the scene, more giving of her time, patient. And I think somebody has something going on. I'm getting beeps, so just make sure there's no background noise. You might hear my dog very soon. And Stacey is a survivor of breast cancer, of a high-risk breast cancer over 2 decades ago. And she has taken that diagnosis when she was very young with a young son, and has broken the glass ceiling and decided that she was not going to be shadowed by it. And by not being shadowed by it, she has not only influenced the way the general lay population talks to one another, but she has influenced how providers should talk to the lay population. And I am really excited to say that she has taken her business acumen several levels to where I'm kind of gaga. So we're going to hear a little bit from Stacey right now, and she'll explain what this means. Stacey, say hello to almost 100 participants who are on Zoom right now.
Hello, and thank you for joining us tonight. I am here clearly because Maria Theodoulou saved my life 21 years ago. And she was just not my doctor. She has become my friend and somebody that I love and adore. And when things were difficult and there were lots of trying times, I hope that I can be a face of hope for a lot of you going through troubled times right now. And, you know, my business is something that I am very passionate about. I run a luxury travel and lifestyle company in New York City. I have clients from all over the world. And there have been a lot of silver linings that have come out of COVID. One is that my son joined my business, and the other is that I formed an alliance with this wonderful female woman of color family business in Chicago who works for the Obamas. So Ashley and I are doing lots of amazing things for people. And that also means it's not just about the money. It's about getting people what they need, but also with care and with heart. So I'm so grateful to Maria for having me be a part of this, and giving back is something that I always love to do.
Thank you, Stacey. Thank you. You can hear the sincerity in your voice when you speak. Joan, I'm leaving you last for a specific reason, okay? So the next person that I want to introduce is Elizabeth Poynor, who has been really my right hand and left hand when it comes to these programs that we've been trying to develop up in this part of the world, in Albany and in the Hudson Valley, to educate patients, to allow them to speak their heart, sometimes talk about things that they would not talk about in the privacy of their own homes, and giving them a forum for well care, and being able to say lots of words that oftentimes they're gun shy of speaking. You know, Liz Poynor was, well, she is a GYN oncologist, gynecologic oncologist. She spent over a decade at Memorial Sloan Kettering Cancer Center, superbly trained, well respected and well honored and loved, and broke off on her own, is associated with NYU Langone, is the president chair and developer of Poynor Health, which really addresses the female, F-E-M-A-L-E, the whole female. It's not just about what goes on below our waistline, but how what goes on below our waistline may make us feel in every other part of our body, and how sometimes what goes on here can affect what goes on in different parts of our body. She has been just a champion of women seeking a holistic way of being young at heart, young in spirit, and always hopeful. Liz, I turn it over to you. I just adore you.
Thank you so much for that great introduction. So I'm a GYN oncologist in Manhattan. We focus on cancer prevention and survivorship strategies to live your best health possible and best wellness possible during or after a cancer diagnosis, and in a holistic fashion, though, mind, body, spirit, working on the body as a whole. And that's our approach. And thanks so much, Maria, for having me this evening.
Oh, it's my honor. You've always donated your time, and you've never said no. And I can't tell you how grateful I am. I do want to introduce everyone to Dr. Heidi Godoy, who has just joined NYOH, GYN oncologist trained at Roswell Park. Very popular up in our part of the world. Patients adore her. She obviously takes care of patients who have all of the diagnoses that none of us want to talk about. We are going to talk about Chris Everett tonight and her diagnoses. And, I want to welcome you, Heidi, not only to the Survivorship series. Hopefully we'll see you much more so, but also to NYOH. We are going to be so happy to have someone with your specialty, with your care, your heart, your charm, being available to our patients. Everyone say hello to Heidi. Hi.
Hi.
Heidi, the audience is yours right now.
Well, thank you for having me. That was very warm and very kind. I spent 10 years practicing in the Capital District, and one of the major reasons why I moved over to NYOH was because of the care they give, because of that all-inclusive care. And Liz, kind of to your point, providing a holistic approach to dealing with a lot of these serious medical issues. So I'm excited to be here. Thank you for inviting me.
Well, we're happy to have you up here. And you know that I'm going to embarrass you, Colleen, who I could disappear at any point in time. Patients would not notice because Colleen is there. Colleen Murray is a nurse practitioner. She worked and trained in the GYN oncology arena for many, many years when she decided to take a hiatus to have her children. She's now the single parent of 2 teenagers. Oh my goodness. And is I could say my right hand, my left hand. That's Liz. I think, Colleen, you're all my fingers. That's what you are. I couldn't keep a busy practice floating without you. I trust you. I adore you. You're my friend. And what a patient advocate. Patients adore her, and you'll find out why. Colleen?
Oh, thank you so much, Maria. I'm so honored to be here. I mean, I'm so lucky to be such a part of this panel with these amazing women. I just can't wait for tonight. I'm so excited. I was like counting the hours till it started. So yay, it's gonna be great.
Thank you. Well, I said, Joan, that I was gonna leave you for last, and there's a reason for it. Dr. Joan Kent is an OB-GYN who has practiced on the Upper East Side of Manhattan for a very long time, over 30 years. I know that I've known you at least that long. I know that I've referred probably hundreds of patients to you over the years, and boy, they loved you more than anything. She delivered all 3 of my grandchildren. So how could I not adore her? There's something about Joan that stands out, and you'll find it amongst all of the panel here. It's a very similar trait. She sits down and listens to the patient before she even starts an examination. She listens to them and she hears them, and she then talks to them. And talk about a holistic approach. She is also someone who has now transferred her practice to straight GYN. Lucky for all of us, because now we can get access to her when she's not delivering babies at all hours. But Joan has a very particular interest that really has piqued my interest, and that's regarding HPV-related cancers. It is something that we don't talk about enough. We don't talk about the vaccine enough, but we don't talk about where it should be used. Is it just our adolescents? And where else should we be thinking about it? And I'm not going to take your thunder away because, Joan, you've been affected by this on a personal stage with family members, and your research interests and your sponsorship of what's going on right now at Memorial Sloan Kettering Cancer Center with Nancy Lee and David Pfister is huge. And the breakthrough is not the risks of an underlying quiescent cervical cancer, but that also translates to anal cancer and head and neck cancer. So Joan, I'm going to turn this right now over to you. And I'm hoping that what we'll do now is all of us, starting with this, have a conversation. That's what we're going to do tonight, have a conversation.
Well, thank you so much, Maria. It's a pleasure to be with you and this great group of panelists. You and I have been talking about specifically the HPV issue for a long time, and I'm thrilled to be able to meet with this group and this audience to kind of bring it to the forefront so more people think about this issue, which is hugely prevalent in the population. 80% of Americans have had an HPV-related infection, not an HPV cancer, because many clear, but many cancers are HPV-related. And excitingly, we do have a means of prevention. We're not as great with screening in all of the different cancers that HPV can affect us with. We're much better with the female lower genital tract screening, but the head and neck cancers, the anal cancers, we really don't have great screening for. So we need to really increase the amount of knowledge that the population knows, let them know this is out there, let them know prevention is possible, and that they need to talk to their doctors about their risks and what they might be able to do about it.
So cervical cancer, when we talk about it, and we talk about it certainly the increased numbers in third world countries, but we see it in our own country here. And it's often secondary to a sexually transmitted virus. And that virus is not just from coitus, or it can happen from oral sex, it could happen from anal sex. Men are affected, women are affected. And I think where we got started in our conversation, I was actually coming to you for my WellCare screening several years ago. And I was telling you that I have, patients that have survived their breast cancer that are now going out into the real world, starting to date. They're empowered. They've decided, gee, I've been in a marriage that doesn't work. Or they're going out and they're going to become sexually active. I'm always concerned about these women. We are living longer today. We're living into our 80s. We're living into our 90s. So even contracting an HPV-related cancer virus when we're in our 40s could be deleterious for us 20 years down the line. So, in talking about that, I became privy to some of the interest that you have and the research that's going on at Memorial. And I was actually very honored that you invited me into a closed door session where they were talking about mechanisms that are being identified where we can evaluate whether a patient has HPV-related exposures that may not be diagnosed via a pap smear serologically. And if they haven't and they're about to go out into the world, maybe that's the time to vaccinate them, and not just when they're adolescents. So I'm going to throw that again back at you, Joan, to hear your thoughts on it.
So the biggest thing that we can all do for our patients, for their children, for their grandchildren is vaccination. And it's always best to get the vaccination done before somebody is sexually active, before they have any exposure. Unfortunately, really less than 30% of eligible young people in this country have been vaccinated. And it's a real pity because the vaccines that are available are effective in preventing more than 90% of HPV-related cancers later in life. So you and I and our patients were not often of an age where they would have been vaccinated before they were sexually active. And in this country, it used to be that insurance companies would cover the cost up to age 26. Now, happily, it's up till age 45, but it is not going to be covered beyond that age. I've spoken to people who were on the committee that made these decisions, and they've also told me that they're not going to do any studies over age 45 about the effectiveness of the vaccination. I tell all my patients about the vaccination because, as you said, many of them are re-entering the dating world. They may have been in monogamous relationships earlier in their lives, but they're ready to date. Men at a certain age are not very conducive to using condoms, which is one way of helping to prevent HPV-related female lower genital tract infections, but it's not even a perfect prevention. You can still pick up HPV from relations, even if somebody is using a condom. But the vaccine is the best we've got. And we're not going to get guidelines that cover our patients after age 45, but I still offer it to my patients because it's what we have that can prevent them, especially when future partners may not want to use condoms. And many men have been exposed to multiple partners. So our patients are going to be exposed to everyone that man has ever been exposed to. So for men and women, I think there's benefit.
Yeah, this brings me back to when I was actually a PGY2. I was a second year resident in my internal medicine program before I decided to go into medical oncology. And I remember I was doing my ER rotation and was called down, probably it was about 2:00 in the morning, to help with a woman who was only Greek speaking, and I'm fluent in Greek, or think I am. And she was admitted with pneumonia. She was HIV positive. She had full-blown AIDS. And so this story is going back almost 40 years. I've just dated myself. And it was interesting when I asked her, I sat by her bedside and I knew that she was not going to make it out of this hospitalization. I asked her what her story was. And she said, I was married and I had 2 children, and he was not a good husband. He was from the same town that she was in Greece. And eventually he left her and she raised her 2 sons by herself. And she married, and she had a successful second marriage and became widowed when she was about 50 years old. And this first husband showed up on the scene, and she felt comfortable with him. She had known him in the past. She had been sexually intimate with him, 2 sons down the line, and had sexual intercourse with him, only to pick up the AIDS virus from him. This was not a promiscuous woman. This was a woman who had only had this first partner who had left her, and then a marriage that was a lovely marriage. And now she was dying from this virus that she picked up from this first husband. And I never forgot that story, maybe because I was so violated by it when I heard it, that when I started to look into HPV, and yes, you may not die from it, but the morbidities associated with it, and there are deaths. It's the 4th most common female cancer out there. What can we do, and how can we pick up some of these early cancers from circulating tumor cells or circulating viruses that are deleterious, and then offer treatments as they become more available. Heidi, I'm going to throw this at you. I suspect that you confront many of the issues that Joan does, on that next level, because, you're the one who winds up taking these patients to surgery for their cancer diagnoses. Are you seeing it? I mean, you're young compared to me, but you've been out there for
not that much.
Thank you for that. I'll take that to bed with me tonight. But are you seeing as much cervical cancer as you saw up at Roswell when you were doing your fellowship? Are you seeing it less so now? What are you seeing by way of this when it comes to surgery? And obviously, Liz, I'm going to throw this at you right after Heidi.
So I think Liz and I probably see kind of 2 different populations. I think being in the city, she's seeing a very different population than we see. We see a lot of people coming in off the hill, coming in from rural towns that haven't gotten screened. And so patients may have been exposed 20 years ago and coming in with advanced cancers because they do not get their screening. They may have had one partner their entire life, and they just never came in. Maybe they hit the system in terms of getting screening and getting care while they had their babies, and then they're coming back in their mid to late 40s and they have cervical cancer. I think that with COVID, we saw two different bumps. We thought that we were going to see a lot of terrible advanced cancers immediately after that first, wave we saw, but we didn't. I think people were so afraid to interact with the medical system for fear of COVID. And so I think that patients probably waited even longer. So there have been a lot of advanced cancers that have come in. So I think that you tend to see these things in spurts, but they can be very devastating. You either see early cancer or you see advanced cancer. I feel like in the middle, you don't see a lot of that with cervical cancer, but it's not just cervix, it's vaginal, it's a vulva. And you can, and you're seeing younger patients affected with vulvar dysplasias and cancers because of their exposure. Specifically, I think that HPV vaccine, which I'm so thankful because we do offer it now at NYOH, was one of the first things that I tackled when I started about 3 months ago. And that I said, we need to get this vaccine here because we do see a lot of people with the precursor to cervical cancer, which would be cervical dysplasia, vulvar dysplasia. Despite being exposed to the virus already, these are great entry points to introduce the vaccine to them, so that potentially if they are having multiple exposures, you could potentially decrease, if they only have a lower risk HPV, you could potentially decrease them being having a reaction and having a higher risk HPV and potentially going on to cervical cancer, vulvar cancer, vaginal cancer. So I think in my practice, it does span early cancer, late cancer. I think with COVID, there was a shift in what we saw. And from my perspective, the HPV vaccine is a game changer. It's not just for your 12-year-old. So I had a 75-year-old in my clinic who is getting married again, and she is HPV positive. And she is like, I would consider getting the vaccine. So paying out of pocket for that type of thing. So I think that unfortunately, what Joan said is that, insurance companies aren't going to pay for it for our older patient population. But I think that is a huge need. And we really should probably look for mechanisms to get this covered for our older patient populations.
And once somebody is HPV positive, your 75-year-old patient, the utility and the efficacy of the vaccine?
We don't really have great data. Joan, do you know of any great data?
But somebody can be positive for one subtype of HPV, but not 16 and 18, which are the two worst players as far as the subtypes go. So even if somebody tested positive at any point in their life against a subtype, we can now do that further testing with 16 and 18, but hey, vaccinate them anyway. It has not been shown to clear an infection they have, but maybe it will protect them against one of the more virulent of the subtypes.
Absolutely.
Well, we just got a question on the chat board that I'm going to throw out to you guys. And the question is a great one. This is a woman who's had a hysterectomy. I don't know the reasons, but she wants to know what should her GYN follow-up screening be if she doesn't have a uterus and a cervix. And I think the mention of vulva dysplasia, and Joan, I'm going to throw that to you. What should somebody be doing once they've had a TLH-BSO or a hysterectomy for whatever reason in the remote past? I mean, I know that I tell my patients they still need to be seen and evaluated. So
they need to be seen and evaluated. If their hysterectomy was done for benign indications, the guidelines are that they don't need a Pap test unless they are for some reason high risk, or they could be exposed to HPV in the vagina and the vulva. But you still need to be evaluated, and the vulva and vagina should be looked at and screened. So even if there's no cervix, which is what we all think of with the Pap test and the screening for women in HPV, their HPV can affect all of those tissues of the lower tract. So people need to be evaluated, and somebody needs to look at and make sure there are no lesions that would go along with the precancerous or cancerous change.
Heidi, hold on tight. You're going to be seeing an awful lot of patients.
I would say yearly. People would think that every 3 years or that every 5 years, oh, I can be seen every 5 years. Well, you're kind of missing the boat. You have lips, you have a vagina, you have, things that need to be looked at. So it doesn't mean that we're not going to use the clamp on you, does not mean we're not going to do a bimanual exam. So just once a year, just mark it on your calendar, come in and, meet your friendly gynecologist.
And I was looking at some of the data that was being published over the past couple of weeks, when I was thinking about putting this panel together before even all of you knew about it. And apparently over this past COVID year, there have been 1 million less vaccines for HPV administered, which means we've missed 1 million candidates for the vaccine, which always saddens me. And then you open up the paper and you read about someone who is very much like you, Stacey, Chris Everett, who immediately came out to the media to talk about her ovarian cancer diagnosis. By doing so, she has really opened up the eyes of so many women and families. And when they look towards someone who is such a huge presence, who can speak about it openly, it makes it less scary for others to speak about it openly. Liz, I'm going to ask you about what is a stage 1C ovarian cancer? What brought Chris Everett to the forefront of being tested? Can you talk to us a little bit about that?
Well, stage 1C cancer is an early stage cancer that is still confined to the cancer is still confined to the ovary. Unfortunately, the vast majority of ovarian cancers we don't pick up early, and the majority are present once the tumor has spread beyond the ovary. So 1C cancer, the tumor is still confined to the ovary, maybe on the surface of the ovary and starting to break out a little bit, but it's still localized to the ovary itself. And so it's super important to realize that ovarian cancer actually can whisper to you. It doesn't, and this is important in the screening and prevention realm. Not only do you need to know your family history so that you can have a conversation with your gynecologist or GYN oncologist about preventative strategies, but also realize that ovarian cancer may have some early warning signs and symptoms, which are extremely subtle, such as a little bit of subtle bloating, urinary frequency, fatigue is one. So listen to your body, and if anything in your pelvis doesn't seem right, get to your physician. But an early stage cancer for ovarian cancer is actually just like with any solid tumor. If we can pick it up early, even pancreas cancer, if we can pick it up very early, or ovarian cancer, if we can pick it up early, two consider very highly difficult to cure cancers, but if we can pick them up early, we can actually treat them and cure them with our therapies that we have currently. But the trick is, with these types of cancers, is getting them early.
And there's no question that understanding one's risks are also important, because it's often a harbinger of what may happen. It's not preordained that it will happen, but understanding your family history, which is most important when it comes to whether it's breast cancer, ovarian cancer, pancreatic cancer, melanoma. We know that there's a hereditary component. Even without a gene mutation, knowing that that history is a valid history in your particular lineage, and knowing how to follow up on it. Colleen, Stacey, I'm going to kind of swing the tennis ball your way, because risk factors can often be genetically driven. And right now, Colleen, I know you're doing a lot of genetic testing and screening. You've been validated. That's what you do for 20% of the time when you're not, with me. I know that Stacey, because of a conversation you had with Liz several years ago, you moved forward with pancreatic screening. Can we talk about that? And then I promise the audience that I will get back to your questions.
Yeah, Maria, I think this is, a huge important conversation to have with our patients. And I know all the other panelists feel the same, and I'm sure we all have the same conversations when we go into a room with a patient is, what is your family history? Many of our patients who have breast cancer will be like, well, my grandmother had breast cancer, my maternal aunt had ovarian cancer. And then that prompts us to have a discussion with them about genetic testing. And, some of these families, you are just amazed about how many different family members will have cancers throughout the lineage. And even if there is no family history, talking to these patients about getting tested, regardless if it's just one person with breast cancer, I think it's really important to test our patients, because at least then we can be very proactive about their health care. Just like I tell the patients, just like getting a screening colonoscopy, we need to be proactive. So if I know there's a risk factor in the family, at least we can be proactive in getting them to the right person, sending them to GI, sending them to GYN oncology. I know, Liz, we send patients down your way often and try to get them the right care.
I hear from a lot of patients, I don't want to know, or I don't want my family members to have to worry about it. I don't want to discuss it. And, genetic testing, if it's appropriate in a particular person, it's appropriate because it empowers one to screen early, to find things when they're surgically curable, to be able to move forward with a vaccination when it exists. There's so much language and there's so much good that can come of it. And I think it's a conversation that has to be held, not just between the oncologist and their patient, the nurse practitioner and the patient. It really should be something that should be held in the primary sector, primary care physicians, family physicians, GYNs. Not everyone is a listener like you are, Joan. And it really is empowering. I know, Stacey, you have broken down walls to find out everything you could about your family, yourself, in order to protect your son. And that is, it's not even something where you should get an award for. It should be something that's a given. But
to me, knowledge is power. And I remember going to one of your forums and meeting Dr. Poynor and her talking about genetic testing. And I was sitting there and I had tried to get genetic testing. My mother passed away at 56 from pancreatic cancer. And then I was diagnosed with advanced breast cancer, no breast cancer in my family, but I was trying to figure out if there was a connection. And then going to a facility in New York, found out that I could do a whole genetic panel. It was like 47 different tests. And I remember being nervous about going and being questioned, but I thought, you know what? I'd much rather know what's ahead of me and how I can educate myself and have some kind of screening and surveillance to just have a better quality of life and live. Because pancreatic cancer, if it's not caught early or detected early, my mother, 8 months later passed away. So fortunately, I'm not predisposed to any of that, but the knowledge of being able to know that is very freeing.
And I think one of the key issues for everybody who's listening, and certainly for us as the panel having a conversation, is when there's a significant family history, there may not be a detected genetic alteration or mutation that we are aware of at this time point today, but the panels are constantly being expanded. The genetic test panels are constantly widening, and we should always be at the forefront of really being proactive. To use your words, knowledge is power. It really is. I know that with the Chris Everett story, her sister died from ovarian cancer, and she moved forward and got genetically evaluated. She carried the BRCA deleterious mutation, and because of that empowerment, opted to have surgical risk-reducing surgery to have her ovaries removed, and the early stage ovarian cancer was found. If she had not been evaluated. This may not have been detected until, it was a much later stage. So it is all about empowerment. It's about having a conversation, not walking away from a forum like this tonight and everyone thinking they're at risk or they should run, waving their hands. Really just looking at your own family story, speaking to your physicians and finding out what is appropriate for oneself. One of the questions that came in, and I don't know if everyone in the audience has access to the chat room or know how to use the chat room, but I know that Heidi, you've been active in answering these questions as we're moving along. So I'm going to read one that hasn't been answered. So get ready, panel. I have been diagnosed with HPV. I do not have 16 or 18. Am I still considered a high-risk patient for female cancers? Or is my risk much less? If so, how much less statistically? I have also asked my gynecologist about getting the vaccine, but I was under the impression it would not be effective because I already have HPV. However, it sounds as though I should still get the vaccine, correct? She does not have 16 or 18. So the answer would be?
That the vaccination could protect her against 16 and 18.
Yeah.
So sure, it's a conversation to have with her gynecologist and hopefully allow her to be immunized against these really, really scary subtypes. The subtype that she has is a high risk subtype because that's really what's reported these days on Pap tests. So low risk subtypes are not really reported unless you specifically ask the lab to look for a low risk subtype. So it's all high risk subtypes that are reported, but it's a step further to say the 16 and 18, which are really the nerve-wracking ones.
Liz, how much cervical cancer are you seeing in Manhattan?
So I see a lot of pre-invasive disease. A lot of our patients are very well educated about asking for a pap smear, having a pap smear. My concerns with this are a couple-fold, actually. One, we're telling people that you don't need a pap for every 2 to 3 years or 5 years, or even ever again if you're over 65 and such. If you've ever had if you've had all normal pap smears. So that lessens the impact of you should have a yearly pelvic exam or yearly visit with your gynecologist. And that so when we tell women that you don't need that, when we tell women that we need this less frequently with our guidelines, it lessens the importance of a pap smear, right? But I also want to make a comment about anal cancer, because anal cancer is a cancer that is HPV related. It is one that is really not spoken about very much. And if you look at the incidence of anal cancer in women right now, it's on a steep incline up. We don't know why anal cancer is going up, but it is going up in women. And it's one to be really aware of. Head and neck cancers are super important, but anal cancers are very important. And a lot of gynecologists now in the in various communities are not doing rectal exams. The gastroenterologist may or may not do a rectal exam. Anal cancers are missed on colonoscopies. A lot of our patients will say, well, I had a colonoscopy, but you actually can't see it that well in a colonoscopy unless you retroflex the scope back and forth. So it's super important to realize that HPV is related to cervical cancer, vaginal cancer, and vulvar cancer, but it's also related, it's also causes anal cancer in women. And women need, if you're not getting an annual rectal exam, you need an annual rectal exam along with your pelvic exam.
That's great.
And that's for women, even those who don't participate in anal penetrative sex, because if you have HPV in your lower genital tract, you're still at increased risk for anal cancer, even if you are not having relations in that manner.
That is super, super, super important, because the majority of women who develop anal cancer are not having regular anal intercourse, actually. So that's super, super, super important.
Well, what a great discussion, it is. I mean, this can go on for a long time, but I do want to take some time and I'll open this up as a ofall, although I suspect, I'm going to hit Liz with some of these questions. Heidi, you do your surgery. I often am a culprit in castrating women at an early age because of their breast cancer. Liz, you perform surgeries in all age groups. I know you've had many of my very young patients. There's a fallout. There's a fallout when we do prophylactic surgeries like taking the ovaries out because of a mutation, or taking the uterus out because of a mutation, or even removing breasts because of a mutation. And I can certainly address that at another program down the line, because that whole breast issue is huge. Not that these others aren't, but there's a fallout with early menopause and symptomology that can affect one's sexuality, one's overall perception of who they are, their overall health on every level, whether it's spiritual, psychological. I discuss decreased libido with my patients. We talk about strategies. I try to find out if their decreased libido is because of some, pathology that they haven't really looked at or confronted, that might be above the neck, the psychological component of it and how much that weighs in. We talk about strategies for any mechanical disturbance because of vaginal dryness or dyspareunia. The fallout is not inconsequential. And we had a program just a few months ago where we addressed a lot of these issues. I know, Liz, you've written a book. I don't know how close it is to being published, but boy, I want that signed copy, and then I'll buy 300 more. Can we talk about that, everyone, Joan and Liz? And certainly, I can say from my perspective, I'm probably the oldest one here by many years. And I can tell you that there's still life and spunk to this lady, and I want to be as healthy as I can be and as active as I can be, and may need some strategies. Thank you, Joan. Let's talk about some of that fallout from some of the interventions that we in the medical oncology arena affect in our patients, our young patients, and even in some of our perimenopausal patients. How do we talk to a patient about their sexual health? Bringing up that conversation. I know Colleen and I have become famous for it in our clinic. It takes at least half of our time in most appropriate patients. Eliciting that conversation, which oftentimes has never been discussed on any level in any environment by these women. Let me start with you, Liz.
I think the best way to talk about
huge topic.
Huge. I think, look, we have estrogen receptors from our top of our head to the tips of our toes, right? We have estrogen receptors all throughout our body, all throughout our brain, our cardiac muscle, our bones and joints, and that all throughout our body, we have estrogen receptors. So we impact. When we have estrogen deprivation, we impact every area of the body, and many of these areas can affect sexuality, right? There's libido is also between the ears, right? Not only hormone levels, but between the ears, but between the ears is actually affected by hormone deprivation. So I think that what you guys are doing is the best thing. Just bring up the conversation. You have to initiate the conversation. Not every woman is going to initiate it with us. We need to initiate that conversation. It needs to be part of our health history. It should be our sexual health history. And then begin to tackle it, right? When there become problems. The problems may be very simple, vaginal dryness. That's pretty straightforward to correct. But other problems such as self-image problems, self-perception, cognitive changes that can occur with estrogen deprivation can be a little bit more difficult and time consuming to correct. However, they can definitely be addressed. It's also important to realize that androgens are very, very, very important in women. And this, I think, needs to be addressed a little bit more. Remember that half of our androgens or testosterone come from our ovaries before menopause. And so that when we ablate ovaries and block estrogen receptors, we're also affecting androgen levels. And that also needs to be addressed. So just have to bring it up and have the conversation.
Also,
that's so true. It's really having the discussion, please.
So a lot of my patients also have no interest in sex because they're exhausted because they're up with hot flashes all night. So you really have to look at the big picture of all the different ways that women are affected by the lack of estrogen, and whether it be hot flashes and they're up and that has changed how they feel, or their vaginal dryness is going to change their libido as well. And if you can break down sometimes some of the different aspects, then you can end up with a better result.
And there are some safe solutions even for those patients who have been diagnosed with breast cancer. We did speak quite a bit about that in the fall when we had a panel discussion. Liz, you spearheaded that conversation. Maybe you can spend 2 to 3 minutes talking about some of these issues.
Right. There are a number of,
obviously patients who have never been diagnosed with breast cancer and those patients who have been diagnosed with breast cancer.
So in terms of women who have been diagnosed with breast cancer, we can use very low dose topical estrogens to the vagina with the approval of the medical oncologist. I always say, I'm going to start with vaginal health first. There are low dose forms of estrogen which have been proven to be beneficial and safe for women. However, always need to be reviewed with the medical oncologist, who I always say is driving the ship when it comes to breast cancer recurrence risk. There are other ways to treat vaginal atrophy and to help with vaginal health. They range from hyaluronic acid, CO2 laser, low dose DHEA for some women may be appropriate if she's on an aromatase inhibitor. So very individualized, highly individualized, medicinal and non-medicinal. Also, we use some natural therapies such as aloe vera combined with hyaluronic acid. In terms of hot flashes, that's sometimes a harder one to impact upon, but there are ways to help manage hot flashes which do not involve hormonal remedies and involve more medical remedies such as serotonin, drugs that impact serotonin level. People beginning to use oxybutynin, gabapentin more frequently for hot flashes. There's actually a newer drug coming down the pike that actually affects the CNS itself, actually for hot flashes, that has no hormonal reactions at all. And then there's this group by you guys who's using like low dose intranasal estrogen for hot flashes, which I thought was fascinating, but that's just a study right now. And but I thought it was really fascinating way to deal with hot flashes. But it's always a conversation. I mean, I completely agree with Joan. It's like you have to break this down, and not every estrogen deprivation is going to impact every woman a little bit differently. And of course, always important. Nutrition is super important. Eating a plant-based diet, anti-inflammatory diet will help with this. Trying to get the best sleep possible, and exercise, yoga, acupuncture can help. It just depends on how somebody wants to approach their health and wellness, and then what specific issues that they are having.
Joan, for a long time, hormone replacement therapy was a given, and then there was a study where there was some evidence that there might be an increase in breast cancer. Prescriptions stopped being written, and that patient who does not have a family history, who does not have a personal history of breast cancer, what do you recommend by way of postmenopausal interference when somebody's symptomatic?
So symptomatic or even not symptomatic, we go through a whole list of the pluses and the minuses of hormone replacement therapy, taking into account their history, their family history, and their thoughts about it. We know that there are some absolute benefits. If you start the hormone replacement within 6 to 10 years of menopause, especially before age 60, decreases the amount of plaque that forms on their coronary arteries, decreases their risk of osteoporosis, helps their hot flashes, helps their vaginal dryness. But there is a slightly increased risk of stroke, a slightly increased risk of ovarian cancer, and the breast cancer risk is quoted as 1 additional case per 1,000 women per year. Now, the hormone formulations that we've been using are very different than the ones that were used in the old WHI study, which was stopped in 2002. We're using really more bioidentical, but FDA approved formulations. We're using transdermal estrogens instead of swallowing a pill. The progesterone we're using is different than that was done years ago. So we are never going to get another huge longitudinal study as big as that WHI study that was done, but we do need to keep looking at the numbers and seeing how what we're using today impacts long-term on women. And again, each person's symptoms are different, and some people who have high risk of osteoporosis are interested in hormone replacement, even if they've never had a hot flash.
So Joan, just to segue into that, I think one of the things that we can maybe tend to do is look at different ways to reduce people's risks, specifically looking at, is there an option for patients that have this hereditary breast ovary syndrome, potentially doing a salpingectomy, an opportunistic salpingectomy at either the time of a cesarean section, at the time of an appendectomy, at the time of other surgeries, or in patients that we know have a BRCA gene mutation, potentially if they're not super high risk for having ovarian cancer in the 30s and possibly early 40s, considering then taking out the ovaries laparoscopically as an opportunistic salpingectomy. And I think that really has taken on a life of its own. And patients that have hysterectomies for benign indications are having these salpingectomies done.
You know, salpingectomies were a topic of discussion during our last panel. Liz, you again was spearheading this, and it was fascinating to me to hear that 90% of ovarian cancers actually evolve from the fallopian tubes, and perhaps leaving the ovaries in these young women and doing in these high-risk patients and doing salpingectomies would be a way to decrease their risk but preserve some of their estrogenic production. I'd like you to give a word on that. And then Heidi, I'm going to come back to you because a question was put up here and you answered it, but I really want the audience to hear it. Please go ahead. Liz?
I think it does. I think that salpingectomies do offer women the ability to obviously retain their hormonal function for a period of time. I actually really look forward to the data, the mature data on this management strategies. I mean, this data is not mature. However, it does allow women to do something to help prophylax themselves against the development of ovarian cancer. And that should always be reviewed with your GYN oncologist and your medical oncologist. And carefully reviewed, but it is important to also educate our general gynecologist on opportunistic salpingectomies. I think that's very, very, very important. I think, interestingly, the concept of doing an opportunistic salpingectomy at the time of an appendectomy or other surgery is great, actually, because there's no side effects from it. So if we can do that, that would be really great also to educate our general surgeons also.
Well, think how many cholecystectomies are done, how many gallbladders are taken out, and how quick it would be just to pop in the pelvis. And take out tubes.
Yeah.
So
my general surgery colleagues could do that.
A question came in, and we're probably going to wind up wrapping up the program with this. Is there any way to eradicate HPV from your body once you have it? Can it not clear on its own? I had a pap smear which showed it, then the next one did not. 2 years later, it showed again. I am only with one partner. Can we keep giving it to each other? Heidi, I'm not going to give up your answer. If you could speak to your answer, and then everyone else can pipe in.
Sure. I said it was all about your immune system. In our 20s, we try people on, right? So you have your highest exposure to your HPV. And does everybody who's been exposed to HPV end up with dysplasia or HPV-related cancer? No. And why is that? Because virus, just like if you get a cold, your immune system has to handle it. And some people have the capacity to completely clear that virus. Other people do not. And when you have the capacity not to clear that virus and you have persistent infection with the virus, that's when you're going to see dysplasia and you're going to see cervical cancer. So one, are you passing it back and forth between your partner? I don't think so. I think that you probably have a virus that potentially became dormant, and there may have been some sort of reactivation of this virus in your system. As long as it's a low grade pap smear, or you're it's not a high risk HPV, if they've subtyped it, then I would say then you're probably okay to continue watching it closely with screening. But I think that the most important thing is not everybody will have an HPV related dysplasia or cancer because your immune system does clear it and that it's doing its job. But people who become immunocompromised, people that have HIV, people that have that are going through cancer treatments where their immune system is compromised, those are people who you want to look at a little bit closer. You want to make sure that you're kind of covering all your bases, that they do have, that you're screening them because they may be at higher risk for an HPV related cancer because your immune system can't come in and clear this virus.
Patients often ask me about breast cancer, and when I'm teaching, I get asked a lot about the different types of breast cancer. And it's not just different subtypes of breast cancer, it's the host that the breast cancer develops in. And the analogy that I use is if I take a packet of seeds for the garden and I share it between the 6 of us and we throw it in our respective gardens, and these seeds seep into the soil, in mine, nothing may happen. Those seeds may just deteriorate over time because the pH, the acidity, the wind, the temperature, all of the conditions were not right. In Joan's, that seed may start to germinate or root, but it doesn't have the potential to move and break the soil. And Liz, that seed may germinate and create a stem that breaches the soil. And now we can see the head, but it doesn't do very much. Where in Colleen and Heidi, the head may start to flower and seeds may start to disperse. But if those seeds disperse in a soil that's not conducive for growth, then nothing's going to happen. And Stacey, you got stuck with the worst case scenario. When the conditions are right, what if they do start to disperse? Even when they travel to another organ site or another garden, nothing may happen depending on the condition of one's environment, stroma, immune system, or something may happen very, very actively. That's really across the board amongst everything that we see in every malignancy, in every medical condition, and everything that we look at in our lives. I'm going to go back to something that Stacey said: knowledge is empowerment. It is something that I know Stacey waves the flag for. I know, Colleen, you have 2 flags that you wave all the time, often sharing your own personal story. We as physicians, Joan and Liz and Heidi and myself, not only try to do what we can to protect our patients, educate them, but also within ourselves, our own families, our own environments, really struggling to do the most that we can with what little time we have available. I can't thank you all for this incredible panel. The time has just flown. I'm excited about tonight being the inaugural program. Thank you, Stacey, for this year. We are looking forward to hosting different panels. The next one that we're going to do, actually, I have 3 and they're all vying for the next month's space. We're going to look at cardiac risk from some of the things we do in the oncologic arena and just talking about well care. We're going to look at bone metabolism and what it means at different levels of our lives and what risks may contribute to a deleterious bone metabolism. We're going to look at sexual health, and we're going to invite back Bridget Finn, our sex therapist, who always entertains the audience. I'll be tapping in on this audience over and over again. We're going to have a program on young patients between their 20s and early 30s, and we're actually going to bring the patients on. They've all volunteered to talk about how this has impacted on their lives. And actually, Stacey, I'm going to ask you to co-moderate that program with me. Some of these women have been diagnosed 21, 22. One has just finished her, not only her treatment and her surgery and her endocrine therapy, she's now pregnant, hopefully with a healthy finality to a healthy baby being delivered. We're going to talk about breast cancer. We're going to talk about some of the newer treatment strategies that have just broken the walls down in the breast cancer arena and some other malignancies and situations associated with breast cancer. We have a lot to look forward to this year. I thank this panel because you've all donated your time. You have not accepted the honoraria that I offered. You've thrown it back into the pool for more programs. I thank you for your work. Joan, what can I say? I think this HPV research that's going on that you are really pushing at is going to change so many young women, middle-aged women, and older women's lives. Liz, I can't wait for your book to come out. I'm so excited for you because you're such a wonderful educator and physician. Heidi, I'm more excited than ever to be working with you. I'm looking forward to a collaboration. Colleen, you better show up on time tomorrow. We have a lot of patients coming in. And Stacey, again, thank you for this evening. Everyone, good night.